Welcome to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. With Innovaccer, everyone works in the service of patients like never before as one. Visit us online at innovaccer.com.
Welcome back to the Innovation Accelerator podcast. I'm your host, Steve Ambrose. How can providers gain a greater ability to meet and exceed the business and clinical performance targets in their contracts? With tighter operating margins, it's become a critical concern shared by provider organizations in both fee-for-service and value-based care environments. Here to help us answer that question and share her expert insights is Amy Stevens. Amy's recently joined the Innovaccer team as our General Manager of Provider Performance and Value Innovation. Amy, it's great to have you here. Welcome to the show.
Excited to be a part of it today. Thank you.
Before we get started, I'd like you to please share a bit about yourself, including your background and current role at Innovaccer.
I'm a long-term health system leader. I've spent over 2 decades inside of health systems, ranging from big for-profits like HCA to smaller regional not-for-profits. I've been a chief strategy officer and a chief operating officer. I was also the leader of one of the very first clinical integration networks formed in the country. And most recently, have spent several years helping health systems, payers, and children's hospitals transform their digital journey. Now here at Innovaccer, what I am working on is the provider experience in terms of getting them to a higher level of performance, particularly with their contracts.
Thanks for that. And in your prior role as a leader of a clinically integrated network, as well as a COO of a health system, you found data to be a constricting force and in many cases, quote, a slam into the brick wall. It's a pretty clear image, and I'd like you to expand on it a bit more, framing it around today's biggest challenges and limitations relating to data in healthcare.
Sure, and I probably can show you some of those war wounds from those brick walls along the way. When you're leading a very large, complex organization, as all health systems are, as hospitals are, as clinical integration networks are, you're trying to pull together a huge variety of functional areas, different disciplines, different applications, and get them to work together. Unfortunately, the core systems that they work on often do not talk to each other. An electronic medical record, for instance, may not talk with a patient engagement tool. A financial tool may have different definitions for what an admission or a discharge is than a clinical tool. And so all across the organization, you have members of our workforce working hard, but working inside of silos. Those silos themselves create data silos. And when you're trying to lead and change performance and ask the workforce to do their work in different ways, in more coordinated ways, over and over again, you discover, gosh, if we only knew what the other person knew, if we only understood it in the same way, if we had it at the right time, if I knew that patient had a social determinant need when they were in my office or on that video visit, boy, could I have made a change, but to get it 30 days later on a dashboard isn't very helpful. So over and over again, these data complexities and lack of connectivity fundamentally affect a very willing and engaged workforce desire to improve how we deliver care and run our companies.
You've spoken about 5, 15, and 80, key numbers that tell a story. What do those numbers mean and why are they so important?
Inside of provider organizations, we care deeply about how care is delivered, but we do also have to rectify how we're paid. And so there have been a variety of models tried along the way, and more of them involve putting risk on actual outcomes, not just did you do the work, did you do a surgery, did you take care of an ED visit? But did the patient's health improve? Were the outcomes of the surgery what were expected? And so more and more, the reimbursement model is shifted towards risk on the performance of our work. But it's been slow. And one of the reasons it's been slow is because people haven't had the tools to do it. What's really exciting, though, is the Innovaccer team has commissioned a study and has recently gotten the most clear view on where we sit in an industry of how reimbursement models have changed and how much money is going to the far end of risk versus sitting in very traditional just fee for service. Did I perform a service? Do I get a payment regardless of the outcome? What that study shows is that we have reached a really important threshold. We now only have 5% of the entire industry's reimbursement sitting in full fee for service. That is a monumental change. We also, though, only have 15% sitting in true risk value-based care payments. So what do we have in the middle? We have 80% that still has performance requirements, but they may not be as strict, as high risk as sits on the 15. What's exciting is when you have different tools that connect your data, give you business insights, give you tools at point of service, that 80% can also be moved effectively. And it can be the same type of tools that you're applying to the 15% and the 5%.
Amy, with its health cloud and data platform, Innovacer operates in a highly commoditized and competitive area. What made you decide to join Innovacer, and in what way do you feel that the organization stands out in this crowded industry?
It actually was a pretty easy decision because it's one of the most fundamental changes and tools that needs to happen inside of healthcare. I consider data an asset, and in the same way you have a workforce, you have buildings, you have managed care contracts. So within your portfolio of drivers, ways that you run your organization, you look across your assets and you say, what can I apply to my problems? When data gets unlocked and you're able to use it much more as an asset, the ability to solve problems changes dramatically. And right now, many leaders out there are struggling mightily with many systems of record, like an EHR, an ERP, financial systems, care management systems. And while we have worked hard to adopt all of these new technologies, each one has a very specific part of the ecosystem they serve. And that's important, that's necessary. But they now need to talk to each other better in real time. And even more than that, we need to be able to level up above individual systems of record and get aggregate views that give us the intelligence to make better decisions faster and with confidence.
Per the 80% number that you mentioned previously, the level of light green money grows as more providers move into greater levels of risk. I'd like you to talk about light and dark green money and how you see Innovacer positioned to make light money darker in the fee-for-service to value-based care shift with providers.
I'd love to give credit to a really strategic CFO that I worked with in the past who used to say, Amy, all money is green, but some of it's darker green and some of it's lighter green. And what he meant in that context was, in order to run a major enterprise, we're talking about billion-dollar enterprises. In order to run that well, I have to have predictability in how likely I am to get revenue. And different types of revenue coming through different contracts, I have to put a discount factor on whether or not there's a high likelihood that I'll actually achieve that money when the reimbursement checks come through. And so as the industry has moved more and more to risk, in many ways, our financial leaders see that as less confidence that money will be dark green money, predictable revenue that will come into the organization. And so for the organization to get that confidence, to feel comfortable signing contracts, going after new business models, new relationships with joint ventures and payers, et cetera, or having their own health plan. They're looking for those tools that will give their team the right information at the right time, whether it's point of care or sitting in rev cycle or working with patient growth and patient journey. They're looking for those tools that give them confidence that as they move that 80% of performance-based contracts more and more into full risk, they actually have a good chance of getting the total reimbursement opportunity, dark green money.
You call social determinants of health and vulnerability data one of the biggest opportunities in healthcare today. How do you see the activated data containing social determinants of health and related information building upon and catalyzing benefit within the risk that's inherent in performance requirements in value-based care and population health contracts?
What's so exciting about these new views that we are unlocking for our customers and ultimately for patients and consumers is that we get to see the 360 view of the patient. Again, one of the reasons why the industry has been slow to move along that spectrum towards fuller risk is the closer you get to full risk, the more you are responsible for the total set of behaviors that the patient engages in, the environment they sit in, and their ability to change and follow therapies, go to appointments, get their medication filled, etc. And it goes deep. I had a pediatric surgeon tell me that he has been unable to perform surgeries as frequently when a baby is born in his region because more and more those babies are born with insufficient nutrition for the tissue to even be strong enough to withstand the surgery. And if that pregnant mother, had been on a different nutrition therapy or regime going into and through that pregnancy, he would have been able to operate sooner, have better outcomes. That's a really specific example, but it kind of brings to life how even the biggest procedures can be affected by the quote unquote simplest things like basic nutrition. What has happened, though, is often we see those data disparately. The patients in the office, the patients in the ED, we've got a care manager on the phone, but at that time of engagement, we don't actually see these other needs that they have. And yet we've signed contracts as organizations that will be responsible for the final outcome, even though we don't even know all these factors that are affecting it. What's exciting is that Innovaccer has built a best-in-breed index. We've taken the great learnings that are out there in a variety of organizations and government entities. We've made a hybrid, and that hybrid, through our data, is able to put a numerical value on whether or not somebody has a high level of insecurity or vulnerability in their ability to manage a chronic disease condition, avoid readmission, and live a healthier life, and thereby, in fact, reducing the total cost and care need inside of a population. By having that index, by having it visible at the moment of interaction, and by having an actionable path, we can, for instance, help them refer to housing through our relationship with Aunt Bertha. By having all of those elements assembled in the right order and in the right person's hands, that person now will actually be wrapped with the services and the information that's needed.
And I suppose this would be a follow-up question here, but your view of Innovaccer is like a power strip that can be plugged into not only by healthcare, but even non-healthcare companies that are involved in health journeys, right? So maybe you can share a bit more about that.
Yes. Because we were born native to technology, we have a very different view than some other applications that sort of came in through another generation or retrofitting, trying to figure out where the world has gone. Our founders built this company, and all of us here that are here today that have contributed to it, built as natives to a digital environment. And so there was forward thinking about not just what we might need today, being able to pull data from claims, being able to pull data from an EHR, being able to pull supply chain or finance data. But what are new forms of data we might need to be able to access and bring in, ingest, and create that more holistic view? We also know that in most cases, we are not walking into a health system or a clinical integration network that has never done anything before. They may already have a patient scheduling tool. They may already have selected a vendor for virtual visits. They may already have a prior authorization tool. And what was brilliant about the Innovacer approach is we said, no problem. Those investments you've already made can plug into, like a power strip, into our platform in areas where you don't have anything yet, maybe related to the patient journey, consumerism, keeping a longitudinal, hyper-personalized view of a patient. Hey, we're building products that can fill that void. But if you're also in the process of buying something new, maybe a remote patient monitoring product for pregnant mothers, no problem. We are already built in a way that allows those to modularly plug in, and we've already thought about it. What makes me super excited is we don't even know what's next yet. So for instance, omics, genomics, proteomics, all of these new digiceuticals that are coming forward, we will not have to retrofit our basic IP, our basic infrastructure, just because the world is advancing. And that's exciting when you're a buyer, to think that you would be bringing in a platform that has already been built in a way that it can expand into the future.
I would imagine too, just a brief follow-up, I would imagine there is quite a bit of obsolescence just from platforms that are sort of more present thinking and not future designed.
There is, and we have some great examples already inside of our company on what could be done to help health systems do what in the industry is called AppRat, application rationalization, said in the more formal way. And that is over time to overcome these barriers we've been talking about, to overcome a lack maybe of a prior authorization tool. They may have financial clearance, but not prior authorization. So they went out and they got just a prior authorization tool, or they got just a patient scheduling tool. Over time, they have accumulated a menagerie of applications. And those applications themselves have changed. What Experian used to do years ago in sort of the old-fashioned credit reporting, they now do a lot of additional services. And the health system has existing products that have expanded that now overlap each other. They've also brought in individual point solutions. And they're looking at this entire set of applications and systems they have in front of them. And they're saying, is there any way to consolidate? Could we go from 14 different systems, as one health system I worked with had just in revenue cycle, to even 4? And if those were 4, what is sitting underneath them that's connecting all of them?
Amy, I wanted to touch on a question here, and I know it's near and dear to your heart. Recent studies show that women at the leadership level in corporations, and we're talking VP and higher, average about 27% of the workforce compared to male counterparts. So female leadership and representation, I know it's important to you, and it's also well supported by Innovaccer. I'd like you to share a bit more about your thoughts around the lack of female representation, particularly in the technology sector.
Absolutely. It is an issue, but I am here as proof that female senior leaders do exist, and we are of high value to an organization in many ways, in the same way my male counterparts are. But we do have struggles that are systemic, and so the opportunity to talk about them and then look inside the organization, whether it's ours or others, to see where those changes can be made. There's great work being done out there by consultants like McKinsey who have really helped us identify where is that funnel drop occurring. And we certainly know a lot of it happens at the very beginning. The type of majors people go into, whether or not they even choose to start science and math early in their, in fact, primary grade years. But there's some pinpoints that we now have better visibility to. One of the important learnings is the biggest drop for females in their progression professionally actually occurs at the first time they are able to be promoted to a manager. That's actually where the biggest drop happens. It's as they call it, the broken rung. So if you never get past that first rung, or that first rung is put this much higher above you, is pushed 5 years out from others, the ability to then continue that progression really changes. So a very actionable item inside the organization is to look at that first level promotion into management and see how well that's functioning. There's also evidence out there that while senior executives are often tasked in their own personal performance to look at things like DEI and equity, they often do not have those same type of metrics at the manager level that are making those first promotion assignments. There's a lot out there on how to provide mentorship for women. Having someone that looks like them in the workplace is incredibly important. I am a blended family. I have children of color, so this also is very important to me, not just as a female issue, but also in other dimensions of diversity. But one of the things I really like to focus on is many times we direct the resources at the affected population, at the females, at those who have color diversity and cultural diversity. Where I'd love to really challenge us at Innovaccer and across the industry is on the allyship. And, said quite simply, females aren't broken. You don't need to fix us. We need to fix the environment around us. So mentoring us more often turns into fixing the females so they know how to behave differently. In fact, we need to turn that lens around and say, how do we give everyone else in the organization the tools to be our allies so that they know what behaviors, what processes need to be fixed as an ally? And that, I think, is one of the most important shifts when we mature through this awareness and understanding and change, is to really think about it holistically as the allies as well as the affected population.
Amy Stevens, it's been a privilege, certainly a pleasure speaking with you. And I'm looking forward to doing it again really soon. Thanks for being on the show today.
Thanks so much for your great question, Steve.
Our thanks to Amy Stevens, General Manager of Provider Performance and Value-Driven Innovation, in sharing her thoughts and insights. And for our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovaccer podcast for more shows covering the healthcare IT topics that you care about. For more information on this and other healthcare IT topics, please visit Innovaccer.com. I'm Steve Ambrose. Have a great rest of your day.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate your transformation and build the future of health on the Innovaccer Health Cloud. For more information, please visit Innovaccer.com.